So the first screening assessment I'm going to be demonstrating in this video is for an abdominal aortic aneurysm. So to start, I'll first be palpating in the epigastric area, just above the umbilicus, at the midline to the left. So I apply a firm pressure and feel a slight pulse. So I'm going to come farther down around the umbilicus and then continue to palpate over the common iliac arteries. So a normal diameter for the abdominal aorta is about 3 centimeters. Above 3 centimeters may indicate an aneurysm, and above 5 is when surgical interventions are further indicated. So here, upon palpation, if I palpate the pulse to feel it between my fingers, and then assess that distance between my fingers by eyeballing it, I can note that this distance does not indicate an aneurysm. So normally, abdominal aortic aneurysms can be asymptomatic, but palpations might provoke some back pain. A sharp tenderness may be farther noted with a dissection. So I bring up my stethoscope to begin the process of auscultation, and I start at the renal arteries, making sure to apply a firm pressure but leaving no dent, as an excessive amount of pressure may create an unwanted turbulent blood flow in the stomach region, which may lead to a false positive test result. And the normal findings with auscultation include hearing no pulse. The presence of a pulse may indicate an underlying bruit associated with the AAA. As you see here, I continue auscultating now over the common iliac arteries, still hearing no pulse. And with this test, auscultation has a very high specificity, but a poor sensitivity. So the next screening assessment I'm going to be demonstrating is used to identify a potential fracture at the clavicle through percussion and auscultation. So I begin by palpating for the patient's manubrium, and then I ask the patient to assist me and have him hold the stethoscope over the manubrium. So then I flex the patient's elbow to about 90 degrees and begin percussing on the uninvolved side and hear a clear, crisp sound upon firm tapping at the olecranon process at the elbow. So I'm going to switch sides to the involved symptomatic side. After confirming the patient is okay, I will begin with percussing again, and the produced noise I hear is a muffled and unclear sound compared to the uninvolved side. So this indicates a potential fracture at the clavicle and to refer the patient out for further imaging. So in this clip, I will be demonstrating how to screen for a potential fracture at the proximal humerus, again through percussion and auscultation. So I will begin by palpating for the patient's acromion, which is a flat surface for my stethoscope to cover, serving as an adequate landmark. So it's important as PTs we don't miss identifying a fracture, as fractures could lead to further soft tissue damage. So again, I asked the patient if he could hold that stethoscope over the acromion for me, and I begin to prepare for auscultation by flexing the elbow to 90 degrees and then firmly tapping at that olecranon process at the uninvolved side, and the sound produced is clear, crisp, with no muffles. And then switching to that involved symptomatic side, again palpating for the acromion process and placing my stethoscope on that landmark. So when I begin to percuss at the olecranon at the involved side, I would hear a muffled and indistinct sound indicating a potential fracture at the proximal humerus, and this finding would urge me to refer the patient out for more imaging. So in this clip, I will be demonstrating how to use a tuning fork to assess for a potential navicular fracture or for pain provocation. So this is a 128 cycle tuning fork that produces frequency waves that cause a vibratory effect and may cause a painful effect there if that navicular was fractured. And I'm going to be testing the uninvolved side's medial malleolus, but being careful to hold it just on the stem, as holding it on the fork part will inhibit those vibratory waves, and I'm testing that medial malleolus just to give the patient an idea of what that sensation will feel like. And tuning forks are good at detecting fractures at superficial structures or long bones. So a positive finding suggests bony involvement, but as always, it's the responsibility of the PT to refer that patient out for imaging according to the Ottawa ankle rules. And here I'm going to be palpating that area of the navicular by looking at the medial malleolus and going up there, finding that prominent bony structure. And since it is tender and painful to touch, I will then place the tuning fork over the navicular after striking it on a solid surface, creating that vibratory effect, and then hold it on the navicular there. And the patient did demonstrate a positive, painful response. For this final screening assessment, I will be doing the patellar pubic percussion test, which uses auscultation and percussion to screen for traumatic fractures at the head and neck of the femur. So I asked the patient if he was comfortable with finding his pubic bone to hold it under his shorts to limit the excessive amount of clothing, as the stethoscope goes in the midline over the pubic symphysis. And I will begin by percussing over the patella after pulling that skin down to allow me to make firm contact with the bony landmark. So the sound is clear and crisp on the uninvolved side, indicating no fracture at the proximal femur. So I'm going to move to the involved side. And do the same thing by pulling that skin back and down on the patella and percussing there. And I do hear a muffled, dull sound. So this positive test suggests a potential fracture, but further imaging will need to be done to clarify if there is a bony lesion present and then to determine the type of fracture.